Right. So may I invite Dr. Jeyanthan, who will be talking to us about, so you've assessed the patient, now it is, we need some equipment in case there is a risk. So what are the equipment and what are the training required for managing these emergencies, and how exactly we can do the code blue drill? So I request Dr. S. Jeyanthan to talk to us about the same.
Thank you, sir. So a code blue means that someone is experiencing a life-threatening medical emergency in your hospital. Could be a patient, visitor, or your own staff. Usually this means an cardiac arrest or a respiratory arrest, especially when the patient has got the symptoms of non-responsiveness, no breathing, no neck pulse. It's called a code blue. Right. How to go about? First, you need to create an infrastructure for provision of emergency care to your patient, staff, and of course anyone who walks into your clinic. This includes the equipment and the trained manpower. Then gather information about the latest guidelines about the CPR. It keeps updating. Just gather the information. Document the code blue protocol in your clinic with everyone's role being detailed. And finally, practice it on a routine basis. So you need to know the key BLS components. It starts with the recognition, the compression, airway, and the defibrillation. So once you know the basic, it is easy to actually equip yourself with the equipment that is required for the code blue drill. The one thing that comes in handy when you need on a code blue drill is this crash cart. It's a multi-drawer wheel cabinet with essential medication and tools that are required in the emergency situation. It's also named the emergency cart, emergency response cart, code cart, and emergency trolley. These cash carts will vary from hospital to hospital depending on the individual facility requirement that is available in the hospital and the patient population that it is catering. A hospital that is catering only to the pediatric has to have a different cash card from that of an hospital which encounters to every age group. So the purpose is to provide an immediate access to supplies and medication, facilitate a coordination of emergency equipment to that particular situation, and saves valuable time at the time of emergency. So it has both the external and internal component. External includes the oxygen supply defibrillator. We'll see that in close. The most important of all this is the crash cart checklist and the drug info sheet. So literally and figuratively, the bigger things are often the equipment you may utilize first, and you want to be able to keep them handy, so they are all kept outside. The first one is a portable defibrillator. There are two types of defibrillator. One is automated, the other one is a manual. In an automated, all you need to do is activate, apply the pads. The pads will analyze the heart rhythm and will prompt say whether you need to give the shock or not. Manual defibrillator, the problem is you need to have a knowledge of what the patient is undergoing, whether to give or not, and then proceed. So it's always better to go with an AEDs. Next is a suction apparatus. So it basically clears the airway and it facilitates the intubation. It prevents the pulmonary aspiration. The other one is the oxygen tank. These are the things which is kept outside. So when it comes to the oxygen tanks, the most important thing is to know where the key is, because most of the time you'll have everything but lose a key, and that's when you'll be searching to crank open it and you'll be finding it difficult. So every component has to be labeled and make sure everything is present on a regular basis. So coming to the CPR, the most important is a mask that has been used in a CPR. A pocket mask or a CPR mask is a must. So it delivers a rescue breath during the cardiac arrest or the respiratory arrest. And the next version of it would be the bag valve mask resuscitator. And this helps in giving a positive pressure ventilation to the patient when the patient has got a breathing difficulty. And of course, the oxygen delivery devices that connects to the oxygen cylinder, the oxygen nasal cannula, the simple oxygen mask, or the venturi mask. Depending on the amount of oxygen that has to be delivered to the patient at that particular position, you need to equip yourself with these masks. So next is the drawers, and there are certain general guidelines how it has to be kept. The first one could be the medication, which you're going to use the next most commonly after the instrument that we have it in the external one. The IV solutions, the adult intubations would be the third one. The IV draw blood supplies would be going to the drawer 5, and the IV supplies and tubings. Finally, all the other miscellaneous, whatever you want to keep, you can keep it at the end. So by this way, it is easy for you to access the most important things. So as I mentioned, you need to have a pediatric resuscitation kit in all the places. The best is to create your own crash cart. See how you are equipped, make your own protocols, equip yourself, and then finally have a sheet which gives an idea of how to move about in your cash cart. Knowing where your supplies are located on a cash cart is as important as having it itself. So navigating your way through a hectic code is much easier when you have an organized system of your crash cart. The most important other one is the maintaining an inventory of your supplies. So remember, when you are in an emergency, you don't want to say sorry when you don't have an appropriate endotracheal tube, or to see that your epinephrine is actually already expired. The adult crash box is a miniature version. This can be kept handy in all the smaller places of your hospital, and it will be easy to carry also. This is basically the miniature version of the crash cart. So this is all about the equipment that you need to actually hold in your hospital when you want to handle a code blue situation. So next part is the training. Why is the BLS training important? Because it increases your confidence whenever an old patient walks in. Even if they happen to have emergency situation, it will be easy for you to handle. You are ready to respond to the emergencies, speeds the recovery of the patient and the survival of the patient. So all these happen only if you have an effective code blue team. So basically, effective code blue team is the one which responds immediately to the situation, gives a high quality CPR and a cardiac compression, have a good code team leader, which all these translates as the improved patient outcome. So how is an effective code blue team developed? It's basically through the training program. The BLS ACLS certification is must for all the members of a code blue team. Initial and annual individual team rolling has to be defined and keep modified. And the leadership training for the code blue team leader is very, very important. So BLS, ACLS, there are actually a lot of ways in doing it. First decide, are you going to learn and teach yourself, your team, or are you going to seek the external agency's help in training? So there are a number of hospitals which is giving this training. So there are two ways. One is having a blended learning, other one is a classroom training. Blended is where you actually read all the theory online and then go for the main session, or you can have a complete classroom sessions also. So you will be given a certificate at the end as a BLS or ACLS according to the amount of training that you get. Basically in ALS you get extra this thing about the ECG monitoring, the cardiac arrest symptoms and the pre-arrest emergencies will be handled. So most of your staffs, all your staffs need to get a BLS training, and the leader should have an ACLS training. If you have an anesthetist in your hospital, that's more than enough, and if they are already trained in an ACLS. So once you finish the training, make sure you have a laminated copies of the necessary algorithm both for the BLS and ACLS. So is this enough? If a CPR is performed infrequently, the knowledge and skills are lost within weeks of training. An in-situ training program every 3 months actually reduces the mean time of to start a chest compression. If you're not having a good training, it'll take 33 seconds. And if you have a regular scheduled sessions, it'll come down to 13 seconds. And the defibrillation timing will come down from 156 seconds to 100 seconds. This is what the study says. So the answer to this is have a regular scheduled mock codes in your hospital. So this actually increases and encourages your staff to do whenever there is an emergency. The first thing is to get a BLS mannequin and have a protocol how you are going to have this code. This is announced as a real code. It can be done 4 times a month. If you have day shift and night shift in your hospital, make sure you do it in both the shifts. And it is being evaluated using a standard form, and it has been reframed by using a simulations. We have certain evaluation metrics both in terms of performance, the clinical performance, equipment availability, and the soft skill of the team. So all these evaluation metrics will actually give a good feedback to the team at the end of the mock drill. Mistakes are okay in a mock drill as long as it helps the staff to do better in the real life situation. Participating in a mock drill on a regular basis is only proven way to boost the performance of your staff. So to conclude, acquire the knowledge, develop an attitude to act on time, practice until this skill becomes automatic for you, retain your skills by doing your mock drills, develop and retain good relationship with your police, fire service, ambulance, referral hospital anesthetists, especially with your own staffs. Thank you.
Thank you, Dr. Jeyanthan. The last slide was wonderfully done. And where do we get this equipment? Because very often in our ophthalmic vendors don't deal with them. So you can use this mic.
regarding the medications, generally, it's always better to have a tie-up with some multi-speciality hospitals. And if your anesthetist is actually, you have a regular anesthetist, they can make the list that has been required for the emergencies, and it will be easy for you to procure through your anesthetist. So it's been regularly done in all the ICUs. So all we need to do is, when you finish your BLS and ACLS, it is better you just have a tie-up with an anesthetist, get the schedules done. It is always better they equip, because most of the time they will be the leader who actually handles this. So if they are comfortable with a particular medication list, get the list and then equip yourself.
Thank you. So now, yeah.
Yes, sir. Yes, sir. So, as a part of our routine practice, we do give Anxit tablet for 2 days prior to the date of surgery. So, this is to not only calm the patient during the surgery, but also for a pre-op workup, pre-op medication. It is better to do that to maintain not only his blood pressure levels, but also his emotional stress part, because what we've observed in our patients is that from the day we've decided the date of surgery, they are always in a tense situation. So it has often helped us to start them on this anxiolytics at maybe a couple of days prior to the date of surgeries. Yes.
Mouth-to-mouth breathing.
So provided if you don't have an ambu bag, yes, definitely this indicated, sir.
No, mouth to mouth in an emergency situation, okay, sir. But when you are in a center where you have all the other support systems in place, better to have ambu bag for efficient respiration. Mouth to bag, in case the ambu bag is not working or it's not available, then we can resort to that.
Actually, to find out the ambu bag and to put it in the patient's mouth, it might take some time. But mouth-to-mouth can be started immediately.
No, that is the reason why we say you need to have all the equipments in place. So a crash cart with all these equipment in place really helps. We start monitoring and do this simultaneously. And if there is a team in place, we can all do the entire BLS within a few minutes.
So there's one more mask which I have shown, sir. It's a one-way mask. So it's a mask with a blower. So it actually allows the air to go through, and it will not allow the air rebound back. It's a very handy mask. You can keep it in your small crash box, and you can place it in the corner of your OPD itself, sir.
Sometimes you cover the mask with the mask, the patient will be tolerable, and what will you do then? Patient did not want to keep the mask as he's suffocating a
No, can you repeat the question, sir?
Why do we cover the eyes with the mask?
Yeah.
The patients are telling that we are suffocating, we cannot get the respiration.
Okay, mask.
They are intolerable.
Right. So
and even a patient get up from bed also.
yeah. So what we do in such cases is we put the oxygen thing under the mask. So once we put the oxygen, they are comfortable. Or there's a lot of air compressors now available. So remove the mask in such patients. So put a drape over that and put the air or oxygen under the mask.
Nose and mouth part of the brain can be cut.
Give it to him, sir.
And the part of the drape in front of the nose and the mouth,
Yeah.
if that is removed, then the patients get calmed. Yeah.
So we do have certain things. We can suspend the mask under the microscope, the drape itself. So, and then, so all these are few innovations that can help in patient comfort.